Good evening, everyone, and namaskar to all the participants, all the delegates, and all our very eminent speakers who've joined us. Myself, Vimmi Choudhry, the facilitator of this meet, and on behalf of IHW Council, a council that has been working towards creating awareness and advocacy for a healthier and happier world, on behalf of them, the entire team, I welcome you all to yet another session, a talk show which is part of a month-long campaign which we are running, the Breast Cancer Action Month, being presented by the IHW Council along with Novartis India. And ladies and gentlemen, as you might be aware that around the world, the month of October is observed as a Breast Cancer Awareness Month. And so as a responsive and a responsible council, this whole month, the entire month from the 1st to the 31st of October, we have dedicated our efforts and this campaign to all the brave men and women who are fighting this dreaded disease. This is a second edition which we have, and wherein our endeavor is towards bringing together all stakeholders, from the policymakers to the experts, the oncologists, the social workers, the influencers, and also the breast cancer warriors, the survivors who have successfully fought and who have overcome the disease. Our endeavor is not only towards sensitizing people, towards creating awareness among the people, but also motivating them by sharing the right knowledge and the maximum information so that the people stand aware, they stand conscious, they stand proactive, and more importantly, they don't lose hope and believe that yes, they can win over breast cancer. And we believe that through our endeavor, if you're able to save even one life, this campaign will be a success. So before we move into today's session, I would like to bring you a recap of all the ground that we have covered till now. We bring you the glimpses of the work done in the year 2020 and then 2021, all the shows through a short video.
As breast cancer is the number one type of cancer in women today.
मुझे आज ब्रेस्ट कैंसर एक्शन डे से उम्मीद है कि जागरूकता और उपायों के बारे में लोगों को बताकर हम देश में ज़्यादा लोगों के बीच कैंसर होने से रोक सकते हैं.
I'm confident that the contribution of the Integrated Health and Wellbeing Council will certainly help in checking and treating cancer.
That this is preventable, provided we feel ourselves on a daily basis. We love our bodies, we value them and take care of them.
The problem is really at two levels. One is with the media centering a lot of communication around what is significant in that month. And the second is, as a society itself, we just don't want to mention the word breast.
We have to create a complete ecosystem so which can really help early detection, early treatment, and help patients live a longer and healthier life.
The most important thing is to be aware of the risk of, that you're a female, you can get breast cancer.
We need a multidisciplinary approach to tackle this menace. We need to have a multi-pronged strategy comprising awareness programs, need to take preventive action.
If we can do the awareness, do the best early detection, if we can downstage the disease from stage 4 to stage 3, even about 20% of patients suppose we downstage them, then I think for last coming 5 years, our job is done.
amongst all, as per the ICMR, recognize that the most deadly one is the breast cancer.
We must channelize them towards adopting a healthy lifestyle that will reduce the risk of cancer.
If our female students become aware from the very beginning of the life, then the chances of breast cancer will be reduced considerably.
Decentralized and integrated breast cancer care supported by data and digital.
It is early is to be treated early. That's the bottom line for me.
You should live each day as it comes, and then you aspire to inspire before you expire.
I see a lot of hope in CSR. Corporates can have a cancer fund for their employees. Why not?
Basically bring the funding agencies together and to channelize, harmonize and prioritize cancer research in India.
Make the education better for consumers, but also the education has to evolve for the medical professionals, the nurses, the health staff and all of that. Put the budget together. How do you find someone to be able to fund all of this?
There must be teamwork or integrated approach of breast cancer management.
It's really about driving education, sharing the latest information, and building a platform to allow exchange of different ideas.
Investment in healthcare has to be pyramidal, with maximum investment being done at the screening level, at the prevention level, and at the diagnosis level.
So as you saw, ladies and gentlemen, through all these events, we have been trying to spread more and more awareness, व्यापक जानकारी दें लोगों को, and especially making the women breast aware and make them speak about it and let them know that it can be prevented, it can be treated. For breast cancer, as we all know, is among the most common cancers in women in India. And according to Cancer Registry, there has been increase in the incidence of breast cancer, and the highest burden of breast cancer has been seen more in the Indian metros. At the same time, I think all will agree that the very idea of getting treated for breast cancer itself, is very dreadful. For the very thought of going through chemotherapy and then all the radiation, it actually sends shivers down the spine. We have advanced treatments which are more effective, which are less painful, but unfortunately, either people are not aware of it or these treatments are not available at all centers across the country. Experts believe that this is actually posing a greater health challenge to women in India, and important interventions are required from various health and other agencies to tackle this challenge. So towards that end, today we have a panel of our health experts, the public health experts, and also the industry leaders who are present with us, and with whom we are going to be discussing and understanding how well India and its states are managing the breast cancer scenario in the country, and what more can be done to make the treatments available. We are also going to be inviting their thoughts on increasing the allocation of funds towards advanced treatment. So with that, let me welcome and introduce our esteemed and diverse panel of experts with whom I'll be taking this conversation forward. From representing the central government, we have Major General Professor Atul Kotwal, the Executive Director, National Health System Resource Center, Ministry of Health and Family Welfare, Government of India. The center has been established to assist in policy and strategy development in the provision and mobilization of technical assistance to the states and in capacity building for the Ministry of Health. From the state government, we have Dr. Pragya Shukla, the head of Department Clinical Oncology, Delhi State Cancer Institute. The institute has been established as an independent and autonomous institution by the government of NCT of Delhi for providing comprehensive management facility with the latest and the most advanced techniques available under one roof for patients suffering from cancer, at par with some of the best such institutions in the country as well as at the international level. And our next esteemed panelists, we have Dr. Rajkumar Ramaswamy, Medical Oncologist, Velammal Medical College, Hospital and Research Institute, This is the largest private hospital in Tamil Nadu, located in the heritage city of Madurai. Our next esteemed panelist is Dr. K.K. Mukherjee, the head of Department Medical Oncology, Chittaranjan National Cancer Institute, Kolkata, a cancer care hospital and research institute, and one of the 25 regional cancer centers of the Ministry of Health and Family Welfare, Government of India. I also welcome our next panelist, Dr. Rahul S. Reddy, Kadarpeta, Health Systems and Financing Expert and National Coordinator, Health Systems Transformation Platform, which is a not-for-profit organization incubated under the aegis of Tata Trust. And their mission is to enable systems transformation towards providing equitable access to good quality, affordable health services. Dr. Kadarpeta's major research interest has been in health financing and universal health coverage, and he has also been advising the union and the state governments, the policy-making bodies, and the not-for-profit organizations. We also have on board Professor Monika Choudhary, Health Financing Expert and Associate Professor, IIHMR University, and Associate Faculty, Johns Hopkins Bloomberg School of Public Health. She, very interestingly, from being a corporate consultant and teaching investment banking, saw her calling in research pertaining to various areas of health economics. She has very closely worked with the government, with funding agencies, also the NGOs, and her consistent endeavor is to develop sustainable models in the healthcare. And then we have Mr. Lokesh Manikonda, the country head India, Arogya Parivar, Novartis. This is a social enterprise addressing health challenges among India's rural poor. Locally recruited health educators are trained to increase awareness about the disease and preventive health. So they're actually conducting health education programs at the grassroots level. And then they also have health supervisors who ensure that the medicines are available and they are accessible in the remote areas. So welcome everyone on board, and thank you to all of you for sparing in your very valuable time and joining us in this educative and informative session. Thank you. So with that, I would like to straight away move into the discussions. And first, may I request Major General Professor Atul Kotwal. So since you represent the Government of India, how do you think the Indian states are faring when it comes to the breast cancer management?
Thank you for this question. I think our listeners probably are fully aware about the the NPCDC as the National Program for Cancer and Diabetes and Cardiovascular Diseases. So in that, coming specifically to the breast only cancer cases only. I would like to put in perspective, that before I go to, specifically give more details about this question as such, that 2018 was a game changer year for as far as, the comprehensive primary health care was concerned. 2018, we launched Ayushman Bharat mission, which has two components, the Ayushman Bharat Health and Wellness Centers, ABHWC, and ABPMJ, that's Pradhan Jan Arogya Yojana. So health and wellness centers are strengthening, and the sub-health centers and PHCs, and creation of a new post of community health officer at the sub-health center level in a leadership role and in a professional leadership role rather. So there, the screenings before that, and I think everyone is aware about the PMJ component, linking the treatment part with the initial primary care. The screening earlier prior to that was only opportunistic most of the time in the public healthcare facilities. And screening as such, I don't know whether in the previous symposia has been discussed the various aspects of screening. As far as lay public is concerned, screening always, entails a lot of controversial debate amongst the public, whether it's the privileged section or underprivileged one. The underprivileged one feels that if screened once, they may not get the treatment, and that is what it happens in many of the LMICs. The privileged ones somehow are discussing more of screening modalities and how many times the mammograph has to be done and what is the sensitivity and specificity and all the screening tests. But to cut the story short, the AVHWCs, Ayushman Bharat Health and Wellness Centers. We started screening for the hypertension, diabetes, and 3 common cancers. That is oral, CA breast, and CA cervix. So for breast screening, and along with this, there was tremendous effort on the health promotion aspects. So preventive, promotive, curative, rehabilitative, and palliative care. That's the entire mantra of the comprehensive primary health care, with all the 12 packages now being made functional. Earlier, it was more focused on the RMNCH plus A and nutrition. Now it is the NCDs, mental health, including the oral and ENT. So in this, there's something called a CBAC form, which is filled up by the ASHAs and the supervision of ANM, which are checked at the community health by the community health officer at the sub-health center level. So the entire population enumeration is done, and all those above 30 years of age are screened for these NCDs which I just mentioned. And breast screening is one of the important components, along with the health promotion activities of prevention of various, information about various risk factors, and also those who are screened negative. Again, they are given more of IECC and behavior change communication, and also the people are being trained in the self-breast examination, which is a major achievement of this. And till date, cumulatively from 2018 onwards, we have had 3.6 crore screenings as far as only breast cancer is concerned. And the numbers are there for the other two, which are tremendous. We have the numbers for who are being, also who are being initially diagnosed and then followed up. That follow-up loop that is being worked upon how to connect with the PMJ, and that has already started. So how these states come up that these frontline workers, as we are aware, have played a major role. There is a heterogeneity in the tertiary care services supply available in the states. The top 5 states with the highest number of active hospitals for breast cancer per 100,000 eligible population are Sikkim, Mizoram, Kerala, Himachal Pradesh, and Nagaland. So although the northeastern states have a relatively lower number of hospitals, but still Sikkim has 2 active hospitals for breast cancer. Nagaland and Mizoram have 8 and 10 respectively. So they emerge at top when we normalize even for the female population as the denominator. The utilization of these breast cancer management services are concerned, it again varies considerably across states. All our indicators, parameters in the health, there's an interstate variation, and of course intrastate too. But as far as CA breast is concerned, now I'll focus on the interstate variation with the states like Kerala, Tamil Nadu, and Mizoram having the highest number of breast cancer beneficiaries per 100,000 eligible female population, and states like Meghalaya, Bihar, Arunachal Pradesh having the lowest, and other states in between. So in order to understand this relationship between the active supply of hospitals and utilization of services for breast cancer by beneficiaries, we need more studies. We have started the health promotion aspects. We have also started the IEC as far as self-breast examination is concerned. We have also started the screening at the community level. We have in the process of establishing, many states have established also linkages with the PMJ for the referral mechanism, and also trying to close the loop of the referral mechanism in a process what we call as continuum of care, when they come back to the community and how continuum of care is there. Under the free drugs initiative by the Government of India from 2016 onward, now drugs are being made available. Under the generics, as per that program, Pradhan Mantri. So there now every district is now being targeted to have one generic store, Jan Aushadhi Kendra, and the aim is that once the districts are saturated, then we move towards each block having one. So there's a move to supply these drugs also, but of course these various factors of interstate variations and treatment facilities need to be looked into, and the important areas of research immediately could be that despite the presence of all this, why some beneficiaries do not avail services early, and many of them, even with screening, they somehow are not too keen to avail services. I think I'll stop here as my initial comments to this question. Thank you, Ms.
Thank you, sir. Thank you for sharing with us the various initiatives which the Government of India has been taking under Ayushman Bharat towards breast cancer management and taking it across states. Here I would like to invite now Ms. Monika Choudhary, Professor Monika Choudhary. Ma'am, what is your take on the performance of states when it comes to women's health and especially on the breast cancer management?
Thank you, Vimmi, for asking that question. You know, probably 1 to 2% of the women in this country go for screening of breast cancer. I don't know. I mean, probably 0.5% of the women would be undergoing mammography every year in order to understand whether they are at risk or not. So, apart from the fact that the government has, taken so many initiatives for awareness on breast cancer or for prevention of breast cancer. We are living in a country where there are so many women who are absolutely illiterate in terms of knowledge about this disease, and because this chunk of people who do not know anything about the risks that are associated with these disease, they become all the more vulnerable. So there are two aspects of the problem, as I can see. One is that once a woman gets this disease, what does she do? Because there is a lot of money that is required to get the treatment done, one. Second is, what does she do to prevent the disease? Because in a country like India, if I look at the statistics on the prevalence of breast cancer, every year about 160,000 cases are added, and there's an average cost of treatment is about 5 lakhs. So, we need about 800 crore rupees every year for the treatment of all of these women, who are suffering from breast cancer. So we need, obviously we need huge amount of money. And I mean, obviously people will not have the disposable income to spend so much of money. Majority of the people will not have money to spend on the treatment of this particular disease. So there are 2 to 3 ways in which we can handle the problem. One is that we expand our infrastructure. We have more hospitals, more clinics where free treatment is available to women who cannot afford the treatment. Second is that we have a risk pool, like for all kinds of non-communicable diseases where lots of treatments are required. We have a separate insurance risk pool, and we have separate policies to cover these kind of diseases. And that would also mean that we bring a lot of people under insurance coverage, because as of now, almost 80% of the population in the country is not covered under insurance, any kind of insurance. So like Dr. Kotwal mentioned, with Ayushman Bharat, the insurance coverage has increased in the last 1.5 years, has increased substantially. And I would like to mention the efforts made by the state of Rajasthan over here, because Mukhyamantri Chiranjeevi Yojana, which is a universal insurance coverage scheme for people of Rajasthan, supposed to be a universal insurance coverage scheme where the poor and the vulnerable groups are offered insurance up to, insurance cover of 5 lakhs. Almost, they are offered this scheme free of cost, but those who can pay, the scheme is offered at 800 rupees of family, which is a very minimum cost. And it will offer a coverage of about 5 lakhs. So we can say that, if there is a woman suffering in the family, if you have a universal insurance scheme, probably there is some way to finance the treatment for her. But for that matter, we need, in order to make this scheme, feasible, in order to make this scheme, this kind of an insurance scheme, scalable. And replicate. And if we look at the possibility of this kind of a model becoming a replicable model for the other states in the country, we need more and more people subscribing to the scheme by paying money. It is not, the premium is not too much. So scalability will happen only, the benefits of scale economies will happen only when more and more people will pay for those for this scheme and will subscribe to it. But I can see the benefits coming to people around me, because a lot of private hospitals, even in Jaipur, there are people coming from all sections of the society to these private hospitals also, and with their RGHS card, and they are availing the service. Now, the third aspect to the problem is, there are these funds, breast cancer funds, which are available elsewhere in the world. They're called pink funds. One of the most popular terms for that is pink funds. So that is a kind of a crowdfunding, that if somebody is suffering, you can, there is a crowd fund that is created, and people can donate to that fund. CSR can donate to that fund, and this pool of fund is created, and if somebody is suffering, they can get their finances from there. So those kind of crowds.
Who's creating the fund?
No, there are these funds are created by NGOs, by civic organizations elsewhere in the world. Not in India so far. What we have in India is some, crowdfunders like Milap, etc., which are for all the diseases, not just breast cancer. So we can have crowdfunding arrangements, like we can have pink funds for breast cancer in India as well. But then again, what is my basic apprehension there is that people who have an access to internet, people who have an access to, who have knowledge about these funds will have an access to these services. But what about those who do not have an access to internet and are not educated enough to avail those kind of services? So, but then I also see some positivity over here. You know why? Because at the Health and Wellness Center, like as Dr. Kotwal mentioned, that Health and Wellness Center, the community health officer posted at the Health and Wellness Center will be responsible for a population of 3,000 to 5,000, 6,000 in his catchment area. And as digital, health IDs are created, and people will have their health IDs, and screening would happen. We will have digital health records in another 3 to 4 years. And with digital health records and, simple ways of screening that are available, cost-effective ways of screening that are available, we will have a very valuable data of people who would be at potential risk, And this kind of data in future, like suppose in 6 to 7 years, we have a data of all these people who are at risk in the entire country. Definitely, targeted interventions can be designed. So I also see with digital health, I think preventive programs can be designed, more promotive health. We can have targeted intervention for promotive health. Like, NFHS 5 data, I was looking at NFHS 5 data, and I found that waist to hip ratio, which is for the first time, waist to hip ratio for Indian women has been estimated. And according to that, 70% of the women in the country are at risk. So, not having an ideal weight is one of the most, one of the important risk factors for breast cancer. So, those kind of things, lifestyle, changes that people can easily make will help in preventing the disease. So, digital digital records would help us to design those kind of targeted interventions for health promotion.
Yeah. Thank you, Dr. Choudhary, for highlighting some of these issues. One, of course, you said that the number of cases are on the rise, and then the cost of treatment is very high, very expensive, and especially for the underprivileged people going for this kind of treatment. and not aware of the financial aid which can be given to them. They're not even aware, because we have under the Ayushman Bharat, we have the Chief Minister's Fund also in various states. But in spite of that, one, they are not aware. So this financial aid for the cancer patients also stands as a concern. And of course, one suggestion which you gave, that probably like we have in the abroad, the crowdfunding. And I know of certain organizations who actually organize these plays and these sports. And you have the players also wearing the pink ribbon, the pink band. And that is how they collect the funds. So probably something like this in a country can also be done. And of course, as you said, maintaining the digital health records is going to be helping us. So, certain issues which you highlighted here, with that, I would like to go to Dr. Rahul Reddy. So, you've been working towards systems transformation, towards providing equitable access to good quality health services. And here we have seen a challenge which is there towards, especially towards breast cancer. So, what have been your observations on the present health scenario, more specific to the breast cancer, and the gaps or the obstacles, impediments which you see, which we need to address?
Thank you very much for that question. I think in this discussion, what is an anchoring for financing and service delivery of cancer care, and especially breast cancer, is having one system which provides care from end to end. That is, from the detection of cancer, either through self-examination or any screening, till complete treatment is done and follow-ups are properly maintained for a particular woman throughout her life, because the chance of relapse is also there. So this end-to-end treatment we see is being provided by several government initiatives that have started recently, but these have been done in a phased manner. Like already Dr. Monika and Dr. Kotwal have mentioned to us about some of these government initiatives, like the health and wellness centers and others that are trying to bring this to life. But the highlight of the financing and service delivery for advanced treatments is through the Pradhan Mantri Swasthya Suraksha Yojana, which is trying to strengthen the existing centers of excellence to provide these kind of tertiary treatments, and also to develop research and and capacity of training doctors, nurses within AIIMS-like institutions in several states. We have seen now almost about 15 to 20 institutions like that being developed across the country in collaboration with the state governments, which is been a tremendous system strengthening effort by the government. And historically also, if you see, there has been a lot of disease burden, mostly on breast cancer in some pockets of the country. And these states have well in advance started developing their own centers of excellence and regional centers of cancer and treatment facilities, like Delhi, Tamil Nadu, Punjab, Maharashtra, Karnataka, Telangana. In the last 2 decades, you see a lot of investments into cancer-related efforts, and especially for advanced treatments. And other initiatives that you see within this sphere, especially in terms of trying to build this end-to-end life cycle for treatment and screening, is also through public-private partnerships that you have between the government and the not-for-profit sector. One such example that you can see is in Assam, where the state government of Assam and Tata Trust have come together with several other partners to engage in the Cancer Care Foundation initiative, where they provide this hub and spoke model of screening and treating all kinds of cancer. And these initiatives have led to not only creating an ecosystem for screening to treatment, but also they help in reducing out-of-pocket expenditures for health. Previously, the speakers have mentioned about the insurance programs, which have increased their coverage and packages for cancer, which also includes these days palliative care, which most of the insurance programs used to not cover earlier. And there is a movement towards covering end life care packages also. And this is going to have a tremendous impact on improving not only the treatment and management of advanced cancers, but also to learn from and to get a lot of exposure to doctors to get trained while doing this. And that leads to further research and development in terms of either newer advanced treatments and drugs, and which is very helpful. And we see these kind of ecosystem that is building will lead us and propel India to better system strengthening in future.
Thank you. Thank you so much for sharing this information. As you said, various states have been very proactive, and they are actually going towards building the end-to-end life cycle treatment for breast cancer. So that is what leads me now to our next speaker, next panelist from Delhi. I would like to invite here Dr. Pragya Shukla. Ma'am, one, of course, if you can reflect on the status and the trends of the breast cancer in Delhi. And two, as I believe that DSEI is the first government institution in the country to have started with the linear accelerator-based radiation treatment facilities. So something which the Delhi government has come up with, probably this can be, the other states can also emulate. If you can also share with us the various other initiatives which the Delhi government has been taking. Ma'am, your mic is on the mute.
Can you hear me, Vimmi?
Yeah, yes, ma'am.
Yeah. So Delhi has its own set of problems. So it's actually a very heterogeneous populations that we are dealing with in Delhi. And plus we have a lot of migrant population. So Delhi State Cancer Institute does not differentiate between a Delhi resident and a non-Delhi resident. So the data that we get at our institute, if we say, because they put in the address of a local relative, so it is very difficult to actually know whether the person belonged to Delhi or had come just for the sake of treatment or consultation to Delhi to one of their known tools. So this is a problem that we are facing right now. Then being a government hospital, which is giving all the facilities other than PET scan, for which also we charge very less as compared to other hospitals in private setup, all the facilities are free of cost. So what happens is that as the resources of the person is drained in the private setup or in the periphery, they come to us through their various contacts. And by the time, unfortunately, they come to us, we get a very less population or percentage who are in early stage. So despite the fact that we are in the capital of the country, we are not getting very early stage disease in breast and other cancers as well. The reason being, what I feel in Delhi itself is that, see, with cancer screening or consultation for cancer, the hesitancy is two kinds. People who are underprivileged or they lack resources, the hesitancy is for the infrastructure and resource that is there. And people who have infrastructure, who are economically and financially well off, so to say, have an emotional hesitancy. So breast screening or breast examination, so to say, or to a certain extent, even breast self-examination has not really caught up in the country to the level that it should have caught up. Because see, cervical cancer, what happens is the female once in the, because we are as a country, as a culture, not to like, no, I want to take it in the wrong way, but we are obsessed with reproduction. Okay, so as soon as a female gets married, she has to, you know, start the family. So sooner or later they go to the gynecologist, and in that process their cervix is examined, and you know, opportunist examination does happen. What is lacking is maybe we can put it in the system, if we can somehow all the gynecological examination and the doctors at the primary level can be trained, or at least the system should be put in their back of mind, that when a gynae examination or for any XYZ problem, a female above 30 years is coming to them, it will hardly increase the examination time by I think 10 or 15 minutes if the breast is also examined. And in the same consultation or same conversation, the female can also be taught as to how she can do it herself while taking bath. Okay, how she has to put the fingers, or how she has to divide the quadrant of the breast in doing that, and like, no, how and how she should and why she should report, and why it is important for early lump to be detected, and the thing that has to be reiterated and emphasized again and again, that cancer is curable. So the hitch for coming to a cancer hospital or a doctor with a, you know, a query question of a cancer lump, cancerous lump, is that achieve kya hoga, uska treatment to hota nahi hai, you know. So then they come to it that a stigma is attached to this disease and the emotional turmoil that they have to go. So this has to be, you know, hammered again and again, that cancer is curable if detected early. So that thing has to be hammered. And when I come to when you look at the lady females in our country more than 30 years, health per se is not of a prime importance of females in our society. So see, barring a few families, even among the socially economically well this thing, if you have to, they have to choose between taking care of the health of a male or and a female, they will always put the male forward. So and that goes across you know, educational strata, social strata, it goes across that. It's there in the country, it's in our blood, that you know, we are made to be, you know, providers. We don't take it for ourselves. Females don't take it for ourselves. We are just there to provide. So we have to inculcate that we can only provide if we have things to provide. If we are not healthy, a person can give only what he or she has. If you are not healthy, if you are not happy, you cannot take care of your loved ones. Okay, so that has to be inculcated in them. Then what has happened is that when you prime the doctors, you know, I have my colleagues, I have my friends, because at the MBBS level, we are not taught actually in the clinics much. I don't know, at the time I was from, we were not taught much about oncology, and at present the doctors around the country are from that part of the you know, generation only. Just making, we were not taught that breast self-examination that much. So it should be a part of the clinical practice and clinical training, that even if you are an ENT specialist, you are going to be an ophthalmologist, you are going to be a pediatrician, irrespective, all of them should be taught how breast examination is to be done and how the patients reporting to them. As soon as you see a 30-year-old female coming to your consultant's clinic or your hospital, you should have this in prime thing, that these things we will examine for this female along with the problems that she has come to us with. Then what is happening is that we are having a lot of NGOs who are doing a lot of work, and that is very good that things are catching up. Cancer survivors coming up with their NGOs, celebrities who are cancer survivors are coming up with their NGOs. But the thing is that everything is very scattered. You know, there is no formed structure, a conglomerate of NGOs who come close, who come under one, kind of a body, like we have, we have Astro, we have ASCO, we have ARI for us, we have a Cancer Society for the country. So can we have a conglomerate or a structured body of the NGOs for better productivity? They are doing immensely in the field. They have a lot of good intentions, but those intentions should reap benefits, and they can be done only if they are done in a structured way. Because see, they want to do a lot of things by virtue of being celebrities. They have funds that they are able to generate because they know the resources, they know the know-how, how to generate funds. They have marketing team who is generating funds for them. But I feel that somehow, somewhere there's a lacking of streamlining or channelizing these NGOs to get the maximum out of them. And then what we are having is that what we are facing as a tertiary, as a super specialty center of cancer care, is that we are getting a lot of people who are not curable. Okay, and the worst thing about cancer is that when it is small, it doesn't cause that much of pain, it doesn't cause that much of problem, and that much of so what happens is the person who has an advanced stage of disease is more in pain, is crying, is bleeding. So the attention and the sympathy, everything goes to that patient, from which unfortunately we are not going to get much. Our resources are channelized to that patient. So we get all calls from MPs and MLAs and media personals that that patient is crying because of pain, is crying because of bleeding. आप please bed दिला दीजिए उनको, ठीक है? I'm okay. See, I know that these patients should be comfortable. I'm not saying that they should be left alone to fend for themselves. But the thing is, these beds are limited. These resources are limited. If we prioritize and we give the resources to these people, what happens? The people who are curable, who could have actually been cured of cancer, they go down. Because
ma'am, I'll come back to you on these because as I know, Major General Kotwal has to leave for a commitment before 7. So I'll take certain questions with him. But thank you for highlighting two major things which you said, that one, we need to create a conglomerate of NGOs who are working in this field so that we have one body and there is a concentrated pool. Yeah. And second, you spoke about that, yes, the awareness towards the self-examination or the clinical examination, that needs to be further strengthened. And towards that, any woman 30 plus, there has to be greater awareness which has been created. And any 30 plus woman walking in for any checkup, probably the doctors or the assistant staff can guide her about the self-examination, clinical examination. So I'll come back to you, but as I said, Major General Kotwal has to leave. So, sir, as we know that the cases have been rising, and in fact, as per a population-based cancer registry over the years, except in Nagpur, we have seen Nagpur has fared really well in that terms. So what do you think has worked right there? What they have been able to do, which has been able to bring down the numbers, and probably it can be a learning for the other states also. We have from Tamil Nadu and we also have from Kolkata here and Delhi, of course.
Frankly, I don't have a clear-cut answer to this. The first thing could be we need to look at data again. Are they screening everyone? Is everyone getting treatment there? Or are the women going outside state for treatment? we need to look at those issues also before we finally say that yes, the numbers are reducing. And secondly, we need to look at, what they have done right, probably. Then we look at this decrease in Nagpur is since many years. It is not since many years. It's a recent phenomenon. So for that, that's why I'm a bit skeptical to, take it as a face value. We need to probably investigate that what were the reasons, and those reasons, that data validity and reliability need to be looked into first before we comment that yes, definitely incidence has come down. So we need to look at that first. That is my opinion, personal opinion.
Thanks, thank you. Thank you. And that probably we'll check on the data and what have been, probably as you said, it's just 1 year back or 2 year back. So we have to see over the periods. Another, sir, with Ayushman Bharat, is Ayushman Bharat now wanting to also focus on the advanced treatment of breast cancer?
Yeah. In fact, I'll share with you. I have the statistics also here that, it is under PMJ, the oncology treat services are the 4th most utilized specialty, consisting of approximately 9% of total utilization by both the count as well as the amount, so, which is a quite large contribution to the entire treatment. And there are 138 packages for breast cancer treatment under PMJ, and either under all the 4 specialties: medical oncology, surgical oncology, radiation oncology, and general surgery. So the treatment is available. 138 packages include all, even up to advanced ones, and the limit is 5 lakh, as you are aware. And recently there is a thought process now, how to increase the coverage. It is till now limited to a particular section of society. So maybe we, as we progress further, it may be expanded, and we need to, the financing mechanism probably will have to be looked at. But I'm not officially commenting on that. But presently, as per the beneficiaries who are eligible, so all these are available to them, which includes the advanced treatment. And you see, the issue now is that we need look at the awareness issue. Not only about the breast cancer, also about the awareness about the packages and treatment modalities available under the PMJ. So those need to be looked at, and there we are looking. I think the NGOs and development partners in the country have got a major role to play in this. Of course, the health and wellness centers are doing the bit. We have 79,000 of them already operational. The target is 1,50,000 till December 22. And the numbers, I have got the state-wise numbers also of how many screening for CA based has been done. And one of the speakers mentioned about data that yes, we have a comprehensive primary healthcare CPHC NCD app. So it's a daily data we are getting, and we have a micro level detail also of each sub health center, PHC, urban PHC, health and wellness centers. How many are getting screened on a day-to-day basis? How many are being referred? How many are finally getting diagnosed? How many are being followed up? So this data is available, and yes, this will finally be integrated into the Pradhan Mantri Digital Mission. The eventual the aim is that all these different kind of apps and different databases eventually get submerged in that, and we have a longitudinal data of each and every individual based on the digital health ID. So where we can follow people and look at really that whether how much screening is beneficial and how people are, whether they are utilizing these services or not. So and even the late stage presentation is another issue which we need to deal at the community level, and even during the encounters, each and every encounter. So there the IEC must also include the late stage presentation also, that the presentation has to be so that women are empowered enough, and they should. So the healthcare utilization by the women, as one of the speakers mentioned, that there are different, there are gender differences, there are socioeconomic differences. We need to address those gender differences for the healthcare utilization, also healthcare behavior. So these need to be looked at. In our society, maybe as far as diet or even the individual risk factors of physical activity or the same, maybe more are taken up by the males, but the women sometimes get so engrossed in their work as such at home or in society. So these things get neglected. We need to address those issues also, in addition to providing all the treatment. And I think treatment is being provided now with 138 packages, as I mentioned. And there's another activity for the treatment which I must mention here. The district hospitals are now also being strengthened. And you all are aware about the program announced just about 3 days ago from Varanasi about the Ayushman Bharat Health Infrastructure Mission. That coupled with the 15 Finance Commission grants, 70,000 crores over next 5 years have been given by 15 Finance Commission. We had a 73rd and 74th Amendment to Constitution 1992, which devolved these responsibilities to the primary, to the Panchayati Raj institutions as well as urban local bodies. That money must go to them to manage their own health as well as healthcare facilities and also in all the social determinants of health. So this is the first time it has happened. So it was envisaged in the at the time of independence. It was done on paper in 1992, but finally on ground it has happened now in this year in July, where money is now going directly to the Panchayati Raj institutions to look at the health facilities. There's tremendous amounts of funds being given for diagnostics. So at all levels. So district hospitals are now being strengthened. There's now district hospital, integrated district health labs are coming up. The block public health units are coming up. So screening and continuum of care are also part of this. And in addition to provision of these diagnostic, district hospitals are now being strengthened not only to work as all the secondary care services, some tertiary care services, and also a large number of them are being converted to medical colleges. So once it is converted to medical college, obviously the tertiary care services are available. And linkages with the PMJ in case with the incidence is low in some states or some districts, the private facilities are already there. With the PMJ, those beneficiaries can always be referred there and followed up back in the strengthened district hospital or the medical college which is there. So this is just, I'm just sharing few of the, which is already there, and the financing is there. The states are already planning this. Operational guidelines are already out. We are now taking the help of our development partners to help in implementation of these in the states. I think I'll stop here. Yeah, thank you.
Yeah, thank you for all the sharing all these interventions. One last question before you leave. Sir, as I know, US has allocated separate funds for different kinds of cancer. So you have separate for breast and then lung and uterus and further. And then it is relative to the prevalence, to the burden, to the mortality rate that these funds are basically allocated or they are prioritized. Does India has any kind of such plans? Is India looking into such kinds?
Yeah, it's a very, very interesting question, and good. We need to look at the US health system. That even after spending so much on the health system by the US government as percentage of GDP, ours is only 1.35 as per the latest estimates. But again, the amount is huge. Their out-of-pocket expenditure is still very high, and people are being pushed into poverty because of this. Our out-of-pocket expenditure is showing a tremendous downward trend. I can't share with you the latest national health account. It is yet to be released, I think, very shortly. But the tremendous reduction over last 7 years has taken place as far as out-of-pocket expenditure is concerned. So we need to first, before we think of this, we need to analyze and do some research on, whether the incidence-based fund allocation, which you mentioned just now, is it really efficient and effective? So we need to look at that US example. We need to analyze it, and then probably we can start a debate on this. So presently we don't have incidence-based. We have the flexi pools. Under the National Health Mission, that's the best part. When the NRHM started in 2005, National Rural Health Mission, and NHM, of course, in 2013 later on, subsuming the Urban and Rural Health Mission. The game changer was the flexible financing, which was not there before 2005. So flexible financing and communalization and few others were the pillars for the other pillars for National Health Mission. So states are free to use funds for one disease to another disease depending on the requirement. So we have that kind of flexibility available. So we have RCH pool and NCD pool, but always allocation within this, they can all again come back to us, and allocation can always be, and some percentage can always be done by them also. This kind of flexibility is available. And so what we believe is that with the population level screening, with the accuracy of information gathered over a period of time, we will be able to get more stronger evidence for incidence. And by that time, hopefully, we will also gather evidence whether incidence-based financing will really be effective and efficient or not. So right now, I think we need to discuss it among the public health specialists and other specialists. And till then, we have the flexibility in financing, which is there.
Thank you, sir. And I think we are building on the digital health repository. We are.
Yes, definitely with the Ayushman, the PM digital mission. With the digital health ID, it will be a longitudinal database for every individual, and it will be easy. So the creation of more and more registries will be obviated over a period of time, and the cancer registry now with the headquartered in Bangalore, it has done a tremendous work actually in a developing country like India, both with the population and hospital-based registries combining the data. And the recent paper at the beginning of this year only, which brought out the trends and all which you mentioned about the cancers and the projections also for next few years. So, but once the digital repository, digital mission starts working fully, it has been launched recently. It will take few years, for the people to get enrolled in that, and then to follow them over a period of time. So gradually, all the information will be available there. And at the sub-center and the PHCs and all the public health facilities, we have wherewithal for the IT equipment. We have funding for the internet, even for the cloud services. Till the time they all link up with the digital health mission. So these kind of activities are there, and data are now being available, which are more robust and reliable.
Thank you, sir, once again, and thank you so very much for joining us today. And thank you for your time.
Thank you, Ms. Vimmi, and I apologize to all the other panelists, for jumping the queue. I have another commitment at 7 o'clock. That's why I had requested. And thank you very much. Pleasure to be here. And I think it's a very important topic, and I must commend IHW for taking up this for over the entire month, because the importance somehow has not been given by the community, and also by the even by the health systems as such till about a few years ago. But now that due importance is being given, we need to work more and work together. Thank you very much. Thank you.
Thank you, sir, again. Thank you. Good day, sir.
Thank you. Bye-bye.
So we've heard about the Government of India's various intervention and the big vision and mission which they have towards creating awareness among the people, and also towards having a database, and which, in fact, once we have that through the Digital India mission, once we have the data in place, we are going to be able to take more interventions and more policy decisions will be taken. So with that, I would like to now go to the state of Tamil Nadu and bring in Dr. Rajkumar Ramaswamy. So once again, coming back to the same question of what's the scenario, the breast cancer scenario which you have in your state, and especially also if you can talk about the initiatives which your state has taken and your hospital also in particular.
Thank you. Good evening, everybody. I'm Dr. Rajkumar, consultant medical oncologist attached to both the private sector in the form of Velammal specialty hospital, as well as the government sector in the Madurai Medical College, as a part of the faculty in the Department of Medical Oncology, Madurai Medical College. So, the greeting from the heritage city of Madurai, where the pink power of the goddess Meenakshi was ruling for historically. So, woman empowerment and the woman enlightenment was there right from the earlier days in the cities of Madurai and Tamil Nadu, southern part of the Tamil Nadu. Is it really translates into breast cancer awareness and the early detection of the breast cancer? Let's see, we'll talk about that. The government of Tamil Nadu is a pioneer. The state of Tamil Nadu is a pioneer in implementing the breast cancer awareness as well as the early detection programs of the NCPDS right from the inception since the early part of the century. So we have right now the Apex Care Center. Apart from the Cancer Institute in Arogya, the private sector, the government setup, we have the Kanchipuram, we have the Apex Care Center, as well as the 8 tertiary care center in the various medical colleges situated in various parts of Tamil Nadu, and 14 regional cancer centers have come up in various district headquarters hospitals, which has been converted, now slowly being converted into a teaching medical college hospitals. So altogether, the opportunistic detection and opportunistic way of diagnosing the breast cancer happens not only in the urban healthcare centers as well as in the rural primary health centers at the sub-center level. So the detection rates are very high, but still we are lagging behind in the sense that still what I see in my practice as well as both in the government sector as well as in the private sector is many of our patients turn up in the advanced stages, that is stage 3 and 4. Majority of our practice, both in the government as well as the private sector, we happen to see the patients only in the late part of the disease, in the advanced 70% of our practice is like that. So unfortunately, we are still have to catch them very early. Even though the opportunistic cancer detections programs in the form of oral cavity cancers, breast cancer, as well as the cervical cancers now slowly coming up in the urban health centers as well as in the primary health center and sub-centers, still a long way to go. And still...
But why haven't we been able to arrest it at the early stage?
Still, the not only the awareness is lacking behind, still the stigmas are associated with it, and the lack of knowledge that the painless lump. Still, even today I have seen a patient, even though I have seen a patient, well-educated segment also. I have a businesswoman who come with stage 4 disease from the urban part of Madurai. That's really sad part. These are well knowledgeable persons. The painless lumps are the one which is has to be subjected to a clinical examination, as well as the still we are lacking behind in the mammographic direction, but beyond the age of 45. Routine mammographic examinations are really not catch up with the population, and self-breast examinations both in the urban as well as rural, you cannot even think about it. In the urban sector also self-breast examination, even though many pink programs, pink October programs are being flashed in the radios, TVs, all medias, still the self-breast examination has to be taken up by the large way to the women community as such. And clinical breast examinations are slowly now coming up. So long way to go to popularize the concept of self-breast examination, which will only help us to catch them in the early part. And the mammographic detections, of course, now all the district headquarters hospitals have slowly being turned into the cancer centers, where the regional cancer centers are coming up with the mammographic facilities, as well as the private sector and the private public participation in the form of PET-CT scans have come up in a big way in almost all the medical college hospitals in Tamil Nadu, but still a long way to go in catching them very early. Still the detection rates in the stage 1 and 2, which was there in the US because of the robust annual mammographic screening programs, which are yet to be seen the limelight in India.
Thank you. So once again, we have towards creating the challenge towards creating awareness and towards early detection. So now I'll move to the state of Kolkata there, West Bengal. And from there, if I can request Dr. K.K. Mukherjee from the regional center, Kolkata. So if you can also reflect on the breast cancer scenario in your state, and again, what are the challenges which you see, initiatives taken by your center?
Thank you for inviting me for this panel discussion. It's very nice. I'm listening for more than half an hour. The different aspects of the treatment, management, fundraising problem in the management of the breast cancer. In West Bengal, the picture is like that. There's in Chittaranjan National Cancer Institute is a regional cancer center, and it is the nodal body of the government in Eastern region to serve the cancer care in this region. In West Bengal, Jharkhand, some portion of Odisha, and this region, and so many patients are coming from this region. Bihar also included in there. The main problem, the two problem in one is awareness. First thing, what is to be done? Awareness about the breast cancer and screening. Most of the time, we are lacking of the awareness also. And for the NGO level, what he has discussed, this is already discussed, most probably Dr. Shukla has pointed out correctly. This is the actual conglomeration of the NGOs is very much required. A lot of NGOs working in this area on cancer or cancer-related diseases, but they are scattered in different aspects. First thing, Mike, if you tell me about for awareness, we should stress in the breast cancer screening and diagnosis awareness. District-wise, different conglomeration of NGOs required, and accordingly it should be done, and government and should be definitely under leadership of regional cancer center or state government or government of India. This is one point. So the second point is, after this point, diagnosis and all these things, the management. And management reasons here, there's all the state medical colleges. Now in each and every district, most probably West Bengal, we have the medical college.
Someone's mic is on. If I can just request to please have your mic on the mute. Yes, sir.
And each and every district or medical college is now is in practice, most probably what we think few years back. Now it is in practically we are getting it, and in this for this reason we can after diagnosis, the management, basic breast cancer management, surgery or chemotherapy, that can be done at district level also. And this decentralization of the management is very much required. And so if it's required, each and every district hospital or medical colleges, there should be primary breast cancer care center. Primary breast care center, it should be there. And if it is correctly, it will be done. The proper decentralization can be done.
There's a mic on of someone. Galaxy 820. I'm getting the. Himani, if you can just
mute the portion. You mute it from the host portion.
Yeah, Himani, if you can just mute.
எப்படிதான் இவங்க எவ்வளவு இடம் இருக்கு இங்கிட்டு தள்ளி நீ பாடிருக்கலாமே அவன் டூ வீலர் காரனுக்கு வீட்டுக்கு முன்னாடி
If each every district hospital or medical colleges, we can use the basic breast cancer management unit, and chemotherapy also. What we also, this is a planning for our center also, to train the more and more people in the giving the chemotherapy. Though it is planned from the tertiary care center, but it can be implemented, it can be executed at the district level. If it can be done, then more and more people can, women can under cancer treatment management. Huge amount of patient cost is involved. That portion is also will be decentralized if it is done at district level. And third point is, one is we must discuss is the palliative care. This ultimately the patient will go to the palliation, one during treatment or after treatment of his total lifetime, anytime. Our center now is stressed in the palliative care. In our one is our out of the city. There's one center is there in Chandanagar, historic city of Chandanagar. We have the Ruplanandi Memorial Cancer League, and we have with the advent of the NGOs, we have opened up a hospice and palliative care unit there, and this palliative care unit is now from this center, it should be cover a larger area through home care, and more palliative care nurse, palliative care doctors and health workers should be trained. And I think WHO is a good step, training of this all these health staffs now related to the palliative care. Calicut is an example for that. In Kerala, they are doing a lot this work for a long time. And with all this aspect, now in Bengal, breast cancer from Calcutta is a major city, metro city, from your peripheral district level, it is now available. And we think in later future, in subdivisional level and micro level, we also reach the screening and the basic management of breast cancer. Thank you.
Thank you, sir. So you mentioned about focus on screening, so catching them at an early stage. Then, of course, you mentioned about the decentralization of management, capacity building training. So, and as you said, that Calcutta has been able to cover a lot of ground on that. So, thank you. Now, I would like to invite Mr. Lokesh Manikonda. Sir, you, first of all, thank you for patiently waiting. You've been working at a lot at the rural level. You're aware of the ground realities. We were speaking about the metropolitan cities where the women still stand so hesitant and they're very shy about even talking about it. Rural India is way back in years. So what are the kind of challenges which you have faced there, and what has been your approach? How towards creating awareness and screening. So if you can share your experience and observations.
Sure, certainly. Thank you so much, and it's such a privilege being over here amongst the August panels. Very quick one, even before I get into the answering the question that you have just asked, Vimmi, what we do is important. What we do is to be known. That is very important. So we work as a kind of unit as Arogya Parivar, which has adopted around 22,000 villages across the country to raise the healthcare awareness. And we have around 300 on-ground soldiers who goes to these communities, each one of them covering 50 to 60 villages, raising the health awareness, and then creating a kind of access for proper healthcare, either for getting them a qualified clinician access or getting a quality medicines through a clinician who prescribes. So now that's the first part of it. Now we've been working on different therapy areas, either anti-infectives, cardiology like NCDs and all that. And off late, we just started coincidentally talking about the breast cancer. So talking about the challenges, it is very well articulated by Dr. Pragya, Shukla, and Monika Choudhry. Now, in fact, they stole all my words which I thought I'll put it across in terms of challenges, and they're very eloquently articulated. The most important thing I would again echo is the health literacy of rural women, which is a huge challenge. And unfortunately, when it comes to choosing a priority about a family deciding to let one child study, it is a boy who gets a priority. Okay, the world over there is changing, but not at a pace that we dream of rural India to change. Okay, but yes, there are certain states which are making a kind of great progress. Now, one is literacy. Second one is the gender sensitivity, because you'll be surprised to know in these villages when we go, hardly there are people who would put their hand up when we ask them, have you ever seen a qualified clinician, a doctor who is MBBS? First thing, they do not know how to differentiate an RMP versus a MBBS doctor, a lot of people. And these PHCs and all those centers are quite remote. It is difficult for them to go and even share their problems over there. So you imagine gender sensitivity, because as a woman, you cannot go and consult and talk to someone, a male doctor, to even tell them about the challenge that they have. Now, coming to the third point, unfortunately, their ignorance becomes such a bane where even in the initial stages, they realize, even without doing a kind of self-test examination, they don't even know whom to go and share and how to share. And they do not know the catastrophic consequences what this would lead to in case in case they don't consult the doctor. This is about, and then stigma. They don't have enough access to consult a gynecologist who is a female gynecologist. Okay, these are the challenges in the rural front, and unfortunately, as you know, doctors to patient ratio is quite skewed when you go to the rural India. And most of these facilities are concentrated towards the tertiary care units, even if they want to go and consult. While there are great good souls in the form of great NGOs, some of the organizations and conglomerates who have come together like Tatas of the world, who have adopted certain states, including the rural landscapes, to do these things very efficiently and effectively. But doing it pan-India, I really loved when someone spoke about how a like-minded souls can come together as organizations to committedly work for it. Vimmi, the one thing that I would like to put it across beyond the question that you have asked is how often people on this panel sitting together who probably could be instrumental in shaping certain possibilities, which at this point in time are beyond our horizon, that we could make it happen, need to come together more often to talk on it. I'll give you an example why. I don't think 3 days back, how many of you have seen when our Honorable Minister of Finance announced about 64,000 crores being announced as, you know, the way they are wanting to spruce up 17,000 rural and around 7,000 urban centers in course of 5 to 6 years. When you see the quantum of money and appetite of the government in terms of wanting to invest, I think it is Monika Choudhary who said it needs around 800 crores annually. You think of the difference that it could make. Probably people like us have to come together, put a kind of blueprint in place, have conviction, take it across, and then make it happen. It's not difficult, okay? And then how to plug it? The second part of this, very important is we are working unfortunately only in 22,000 villages, but you would be surprised to know if there are 80 people who attend every health education meeting that is conducted by our health educator, 60 of them are women. I mean, 60 to 70% of them are women. So it clearly is evident that health-seeking behavior in women is far well placed than men. Men choose to do what seem to be their priority, either working or doing something else. But then women are very keen when we invite them from communities to come and attend the health education meeting, and 60 to 70% of them, women coming in itself is an endorsement about their health-seeking behavior, is a huge credibility. All that we need to do, like organizations like that of ours, few more companies need to come forward, few more organizations need to come forward, adopt some set of villages, walk into the villages, especially the women power. You also imagine 2.3 million health workers, either in the form of Asha and Anganwadi. They can change the world for you. First of all, they are the first spokes into the communities. Could we connect with them, accord a priority, run a kind of campaign for 2 to 3 months, or maybe 6 months? But unfortunately, we have done everything in bits and pieces. If we have to do it comprehensively, we need to know how to engage with them in terms of plugging them. Then the kind of, the facilities that we need to arrange, it is very important to see how we go to the PHCs, how the likes of Tata's can, like I was very impressed, one of those organizations in Brazil, I think, have got a kind of mobile, mobile vans, which runs in, which has got a carved out, path in terms of villages that they would cover, and they would be defined destined dates. And each of those cluster of villages would be brought to one particular place, and the scanning happens. Once the scanning happens, then the another one comes where the doctors would define and follow the entire patient journey, right from the prescription, from the follow-up, and what is the outcome. So we need to think such kind of innovative ways. I'm not talking about things which have been very well covered by other eminent panelists. These are my views at this point in time to protect us.
And also in terms of the treatment, and because it is an expensive treatment. So what has been your experience again in rural India?
I would, yes, that's a very pertinent question, Vimmi. I was working 10 years back into oncology, and that's where we were talking about the kind of incidence rate was around 78 to 80,000 cases and per annum. It today is so gut-wrenching to see it is doubling up in 10 years to 160,000 cases. And when it comes to therapy care, it is not all that difficult. One of the biggest gaps in the system is not the cost of the treatment. For example, I know it is little technical, academic in nature if I talk about, if it is hormone receptor positive cases where 50 to 60%, I know the doctors are present over here, so it is them who should be talking about those statistics. It is easy for them to guide to a therapy which wouldn't be such a cost, which would be 300 to 400 rupees per month. And like, for example, Novartis as an organization, globally, we have an access program where any therapy for breast cancer, for example, products like anastrozole, can be bought into India for 70 rupees per month for entire therapy. So we need to think of how we can optimize. People like whether private sector like Novartis, some NGOs, some of these, the bright minds sitting in on this panel can come together, put our hands together, and how could we bridge the current existing gaps can be thought of. And lastly, sorry, we talk about Ayushman Bharat. We've been doing a kind of work along with Ayushman Bharat in a state like Bihar. It is wonderful to get those schemes across for the, for those people who are underserved. Unfortunately, a lot of people, I would say 7 out of 10 people would not even know their entitlements, that these things are covered in them. They received a kind of letter from the Prime Minister that this scheme is launched, and they think that is a kind of ID card for them to go and get enrolled in any hospital. Now we are running a campaign to tell them how to register and how to really make the entitlements come true for them when they are at a crossroads of such challenges of health and life. And this needs to be done on a bigger scale.
I think, yeah. So all of you, in fact, have spelled out not many issues which are there, especially in rural India, because literacy itself, they're not in terms of forget about being hesitant or being shy. They are not, in fact, aware of one, of course, sharing it with their family, and then even if they share it, women are usually, as you said, in a family, she has to take definitely a back seat, and in terms of spending again.
Exactly. And I'll tell you, when we go into the communities, because we work with communities, we have done around, we have touched lives of around 64 million people. Whenever we go into the villages, I have one of the doctors by name Dr. Pyle who works along with me. We all are together. There are male doctors who are qualified doctors who come and run the camps, but they choose to request this Dr. Pyle to come separately into a room so that women can share those problems. Even smallest of problems, saying there's a chest pain or there is a knee pain, they can't even come and talk to the doctors. It is this doctor who is invited to come and speak. So we go and counsel, saying that we have a, we have a limitation that we can't treat you, but this is the doctor who comes to your doorstep who could do that. So this would remain. This would take some more time. Hopefully it would change.
Yeah, even in the metros, women would like to go to a female doctor only for any kind of health checkup, and so
my mom is 72. Still, she asks for a female gynecologist. That's the life. That's the world it is.
Now, unfortunately, we just have 2-3 minutes left.
I want to put.
Yeah, ma'am, please, yeah.
Yeah, see, this, the message that the 2 things I want to really, across the board, I would request, and you also as a female must be meeting a lot of people. See, please dispel this fact that because of financial restraints, you cannot get treatment for your cancer. Okay, so there are resources. We have CM fund, we have PM fund, we have the dark facility, Delhi Arogya Kosh. We have all the MPs have funds earmarked for, cancer care and cancer patients, and they have means of procuring more if it is, utilized fully. So एक ये जो डर है लोगों में कि पता भी चल जाएगा तो ट्रीटमेंट इतना महंगा है कि हम नहीं करा पाएंगे. This has to be dispelled. Like, no, it has to be hammered again and again. Ki there are ways of getting it done. There are institutes who are doing it free of cost. Jao to treatment to karao. I cannot go to a person. मुझे आकाशवाणी नहीं होगी कि वहाँ पे एक कैंसर पेशेंट है. आपको आना पड़ेगा मेरे पास. Right.
Ma'am, we state governments have to do a lot towards that, creating awareness. वो आप लोगों की तरफ से आएगा.
And see, and one more point, this thing that the treatment is very having lots of adverse effects and ye ho jata hai, aisa ho jata. See, those are bygone era. We have now modern medicines, we have modern machines, we are going for targeted therapies. हर चीज का हमारे पास पहले से हम precaution लेके चलते हैं. We have medications, nausea, prevent. See, all whatever artificial exogenous thing you take will create issue in the system. That is nature. We are playing with nature. But ये जो इतना डर हवा बना दिया है कैंसर ट्रीटमेंट का कि ऐसा हो जाता है वैसा हो जाता है, ऐसा नहीं होता है. And दूसरा जो है कि like no, your hair will be lost, but the hair is lost, but then it comes back also, right? है ना? It's not that it's gone forever. And when a thing of vanity, ये आप खुद रहोगे तब तो ये होगा. And people look glamorous without hair, they do such nice eye makeups and everything. I really take pride in showcasing those females. So this has to be dispelled. And मेरे को लगता है कि more than the doctors, people like you who interact with people, who get to meet people, common people, like we meet with people who are from the fraternity, who know most of the things. But आप लोग जैसे लोग हैं जो बाकी लोगों से मिलते हैं, and you have to put that across. बेचारे जो NGOs हैं, मुझे ऐसा लगता है they are like वो बेचारे हाथ पैर मार रहे हैं, but they don't know कि हम क्या करें. There's no guidance, proper guidance. So all this policy, I must say, the policy that is being drafted by the government, by the state government, by the central government should have clinicians in them who are doing clinical practice day to day. वो देख रहे हैं लोगों को कि क्या problem आ रही है. मैं यहाँ पे I am पूरे दिन batting करती हूँ bed arrange करने. We need stand-alone palliative care centers ताकि जो early detected patients उनको treat तो कर पाए हम.
Ma'am, probably आपके cancer, all these health centers, probably you can have those awareness campaigns running. जैसे आप driving license के लिए जाते हैं, वहाँ वो पूरा दिखाते हैं कि किस तरह से driving करनी चाहिए. तो उसी तरह से women.
Maybe what is happening is we see जो treatment है, वो it has to be done by the clinician. But this awareness, see, we'll be misusing our resources अगर clinicians इसमें involve होते हैं. We should do the focus on treatment. ये जो है हम एक बारी we incorporate all the NGOs और उनको हमने conglomerate बनाया and we teach them how to go about it, and then they should be left alone to spread the word. And while we focus, the clinicians focus on treatment. I know it's a long battle. It's not 1 hour ka, discussion. I can go on and on because I'm so passionate about the whole thing.
In fact, we've been discussing.
Yeah. Thank you so much.
I can see that. In fact, because we have run out of time. So the last word from everyone, I'll like to go to Monika Choudhary. Building the sustainable model towards treatment and care of cancer patients, breast cancer. So I'll start with Monika Choudhary, and if each one of you can just 2-3 bullet points you can extend. Yes, ma'am.
So I would like to say insurance pool, universal insurance coverage, awareness about the disease, particularly at the grassroots level, and awareness about the benefits that are available to people, not just for this disease, but for all NCDs. So government is making a lot of efforts, but awareness about those benefits, so that these benefits can actually be extended to people.
So awareness about the disease, awareness about the treatment, and universal insurance coverage. If I can request Mr. Reddy, Dr. Reddy.
Yeah, in addition to what the other speakers have already spoken, I think we need to also focus a lot of financing and funding for research and training and education of nurses, doctors, and other allied professionals who are providing this end-to-end care, starting from screening to palliative care and end-of-life treatments. It's very key that governments also now start spending on the research so that we have advanced treatment so that people can get relief and cure, avoiding relapses and other comorbidities during the process of treatment.
So investment on research and towards capacity building and training. If I can request Dr. Ramaswamy now.
I beg to differ with Dr. Pragya that the financial toxicity, as a clinician, I know financial toxicity kills majority of the patients in the end stage. the financial burden is a huge one, and people, she talks about so much of funding is there and all, but example, if you take, if I refer the patients to far off place where the treatment will be free, many of them refuse to go, and still the stigmas associated with the breast cancer is great in the rural population. People don't tell the neighbors that they are going for a treatment, they're getting treatment under me. So hair loss is a big taboo, big, very big, because hair loss will expose this patient to the neighbor that this patient is having cancer. The cancer treatments in the rural area, I don't know how Pragya's fathomed those, all these things. I have personally seen these patients discreetly, they not to reveal their status, the cardiac status. People nowadays, with the pride of, they say, I have 3 stents in my heart, but I have yet to see people saying I have both my breasts are removed or something like that. Maybe an urban phenomena, but in the rural centers, people discreetly get treatment under me. They don't.
So I would, because we are just, I'm requesting for concluding remarks. So from your end, what needs to be done so that the treatment reaches the awareness?
Still the private insurance as well as the many of the government insurance doesn't covers all the treatment modalities available for the cancer patients. Still, the oral drugs are not approved. I don't know how far the other people face it. We face day in and out. The oral injectables are allowed, and the private insurances with the government set up. The orals are not allowed. There's so much of it, and stigmas associated in the rural segments has to be destigmatized, has to be done through various popular medias, and that's still long way.
Again, towards awareness, Dr. Mukherjee.
I have actually pointed out 3 points from lectures: awareness of diagnosis, disease, and awareness in the female population. This is 1 point. Decentralization, the diagnostic process, and treatment. Third is conglomeration of the NGOs who are acting on health NGOs for early diagnosis to palliative care. Thank you.
Thank you. And now I would like to request Mr. Lokesh Kumar.
I think it is very well covered. I would say, for me, the priority at this point in time, if I have to stack it up, intersectorial coordination would be the most important thing, because when many of us come together, we could be a powerful force to reckon with to address the challenge. The second thing would be having a kind of helpline. There are challenges where you would have counselors and doctors for them to go and consult, but having a helpline where they could anonymously communicate, connect, understand about the disease, understand about the consequences, and understand about the possibilities of getting it treated. What are the facilities existing? I think that would change the the entire paradigm of the challenge that currently we have. Lastly, we have a very I covered it in my earlier talk, that 2.3 million people on ground, Asha and Anganwadi workers, are a force to reckon with. If they could be given some responsibility, if we could engage with them to start with, because most of them are women. I get to see, for us, when we have to go to the villages to mobilize the community, it is these people who help us. If we could engage with them, that would be the first best step to go on a big scale.
Thank you to all of you. So the first thing is towards creating awareness, whether it is about the disease or about, of course, the treatment, and then the various funds which are available, and communicating to them that yes, it is preventable, it is curable, and there are facilities available. So towards that, thank you to all of you for sharing with us the status and the trends of breast cancer in India. And I'm sure all what you have shared, it's going to be put across. We had from the Government of India, we have from the states also. Hope we are able to take appropriate action to strengthen our efforts to improve the breast cancer prevention and control towards achieving the non-communicable disease targets and the sustainable development goals. So with that, once again, big thank you to all of you.
Thank you. Thank you all.
Thank you all.
Thank you. And to all our participants, please continue to tune in to our other programs, the other events which we are going to be taking. As I said, it's a month-long events which we are having till the 31st. So we look forward to your active participation in those events also, towards where we share more information with all of you. Thank you again.
Thank you. So well organized. All credit to you.
Thank you. Bye. Good day.